3, 2, 1.
A very good morning to all of you. And again, welcome to the teaching session of Department of Urology, Savai Mansingh Medical Paper. So today we have a teaching class on anterior urethral stricture. So this will be presented by Dr. Sanyam Nandwani, our resident, and this would be moderated by our faculty, Dr. Manoj Bhavani. So, Dr. Manoj,
yes, sir.
Invite our resident for the presentation. Go ahead, please.
Thank you, sir. Thank you, sir. Good morning, sir, all of you. And I invite to Dr. Sam to present your case, anti-urethral stricture evaluation.
Thank you, sir. Thank you, sir. Am I audible, sir?
Yes.
Is my screen visible?
Yes, audible. And screen visible.
Sanyam, share your presentation, please. Yes.
My presentation is visible, sir?
Yes.
Very good morning to one and all. It could not have been a more proud day for me to give this presentation, as our teacher, Dr. Shivam Priyadarshi, was yesterday crowned as President of North Zone USI. Congratulations, sir, from all the residents. And my very beloved seniors won the quiz contest at the recently concluded 31st North Zone USI conference in Delhi. So congratulations to all of you. Starting off with the presentation, the topic of my presentation is anterior urethral stricture and introduction and evaluation. The topic will be covered under the following headings. Quickly moving on to the anatomy of male urethra. It is a tubular structure extending from the neck of bladder to the external urethral meatus and is 20 centimeters in length. It is divided into two parts, the posterior urethra or the proximal urethra and the anterior urethra or the distal urethra. Posterior urethra, it is 4 centimeters in length and lies in the pelvis. It is divided into pre-prostatic part, prostatic part, and membranous part. The anterior urethra is 16 centimeters in length and lies in perineum and penis. It is divided into the bulbar part, which is in the bulb of the penis, and the penile or the pendulous urethra, which is within the body of the penis. This is a diagram showing the position of the urethra in relation to the corpus spongiosum. The urethra is eccentrically placed in the corpus spongiosum within the bulbous urethra, and as we move distally, it becomes centrally placed. Moving on to the blood supply of the urethra. Urethra has a unique dual bipedal blood supply. The proximal urethra is supplied in an antegrade fashion, and the distal urethra or the anterior urethra is supplied in a retrograde fashion through dorsal arteries as they arborize in the glans penis. It is important to preserve this retrograde blood flow during anastomotic urethroplasty. Otherwise, this can result in urethral ischemia and recurrence of stricture. The internal pudendal artery, which is a branch of anterior division of internal iliac artery, gives off perineal artery and the posterior scrotal artery and continues as the common penile artery, which gives off the bulbar arteries and the circumflex cavernosal arteries. The central circumflex cavernosal arteries, common penile artery goes and divides into central cavernosal arteries and the dorsal artery of penis, which goes and arborizes and penetrates into the spongy tissue. From where, then from the glans, blood flows retrograde into the corpus spongiosum. Within the spongiosum, there are typically 2 to 3 urethral arteries. Earlier, it was thought that the urethral arteries were located at 3 o'clock and 9 o'clock positions, but now, currently, it is considered to have a variable position with equal distribution present around the clock. The venous drainage, the anterior urethra drains into the dorsal vein of penis, internal pudendal vein, and further into the prostatic venous plexus, and the posterior urethra drains into the prostatic and vesical venous plexus into the internal iliac vein. Moving on to the definition of urethral stricture, it is a fixed narrowing of the urethra such that the lumen will not accommodate instrumentation without disruption of the urethral mucosal lining. The stricture distribution being it is most common in the bulbar urethra, ranging from 44 to 67%, penile urethra ranging from 12 to 39%, bulbar plus penile 6 to 28%, moving on to external meatal, submeatal, membranous, and prostatic urethras. Anterior urethral stricture may be associated with scarring process of the corpus spongiosum, which is given the term spongiofibrosis. Posterior urethral strictures as such are not included in the common definition of urethral stricture. By consensus of WHO in 2004 and later by ICUD in 2010, the term stricture was limited to anterior urethra. Distraction defects was a term given to defects of the membranous urethra associated with pelvic fracture. Urethral contraction or urethral stenosis is the term given to other narrowings of the posterior urethra. Moving on to the classification of urethral strictures, divine classification, it is given according to the anatomy and extent of spongiosal fibrosis. It is divided into 6 types. The first being a mucosal fold, which is a stricture without any spongiofibrosis and an epithelial flap. Second being epithelial scar with minimal spongiofibrosis. Next 3 being full thickness or maximum spongiofibrosis with increasing amount of spongiofibrosis. The last being complex stricture complicated by a fistula. The problem with this classification is that an accurate tool to determine and evaluate the degree of fibrosis is practically not available. In an RGU, we can come to know about the luminal narrowing, but not about the character of the underlying tissue. In physical examination and uretroscopy, it can help us to determine the underlying fibrosis, but the extent of actually reliably predicting it is fairly limited. Ultrasonography can tell us about the fibrosis, but is highly operator dependent and is very subjective. Ultrasound classification on anterior urethral strictures given by Mechanic, it is based on the degree of luminal occlusion. It is divided into mild, moderate, and severe. Mild being less than 1/3 of the lumen occluded, moderate being 1/3 to half of the lumen occluded, and severe being more than half of the lumen being occluded. Chow et al. Classified the anterior urethral strictures by combining the sonographic findings and the length of the urethral strictures. Short strictures, it was divided into 5 types, with short strictures being less than 2.5 centimeters in length and long strictures being more than 2.5 centimeters in length. Short strictures were further divided into minimal, moderate, and extensive, and long divided into moderate and extensive. It has to be remembered that the moderate is the term given when some amount of normal spongiosal tissue is present in the periphery, and extensive is usually given when there is a full thickness involvement. Etiology of anterior urethral strictures, it is classified into iatrogenic, traumatic, inflammatory, idiopathic, and congenital. Iatrogenic strictures usually result from urethral instrumentation, whether for diagnostic or therapeutic purposes. Procedures commonly implicated include a diagnostic cystoscopy, urethral dilatation, transurethral procedures, prior hypospadias surgery, and or radical prostatectomies. They are usually from a result of direct insult of mucosa or from inflammation and subsequent ischemia resulting in fibrosis. Factors affecting the formation of iatrogenic strictures include the type of technique used, the caliber of instruments, and the time of the procedures. These iatrogenic strictures typically occur at sites of greatest compression and ischemia, that is at the points of urethral fixation or lumen narrowes, which include membranous proximal bulb, penoscrotal junction, and the fossa meatus. A word on catheter-related urethral strictures. These are usually more prevalent in low and middle and income countries. They result from injury, pressure necrosis, or inflammation. They depend on material of catheter use, insertion technique, and time of indwelling catheters. Traumatic strictures usually result from blunt or penetrating trauma. Straddle and dissolution injuries are known to cause traumatic urethral strictures, with mechanism being the corpus spongiosum being crushed against the inferior pubic rami. These are usually short strictures and occur in bulbar urethra. Inflammatory strictures, they usually occur secondary to gonococcal urethritis, which is fairly uncommon now. There are abscesses in the periurethral glands of litter, which affects the surrounding corpus spongiosum, and healing occurs by fibrosis and scarring. Periurethral glands are usually found in the mid and proximal bulbar urethra and distal penile urethra, and hence the location of these strictures. It has to be remembered that there's currently no clear association between NSU or non-specific urethritis caused by chlamydia and uroplasma urolithicum and development of anterior urethral strictures. Long tortuous strictures with fistulas or abscesses are commonly seen in tuberculosis of the urethra. A word on lichen sclerosis. It is currently the most common cause of inflammatory strictures in Western countries. The disease process usually starts in the glans, meatus, and preputial skin. First, there is a meatal stenosis, which results in high pressure voiding. Then there's intravasation of urine into the glands of litter, resulting in inflammation or literitis, further leading to fibrosis and scarring and formation of a stricture. These strictures can also go on to become a panurethral stricture. Babagli classification is used for inflammatory strictures caused by lichen sclerosis. It is divided into 4 stages. Stage 1 involves the foreskin. Stage 2 involves the foreskin, coronal sculptus, and meatus. Stage 3 involves the above structures and also fossa navicularis and anterior urethra. Stage 4 is when it is associated with the pre-malignant or cancerous lesion. Idiopathic strictures are usually short strictures and probably caused by an unrecognized childhood perineal trauma. A small word on congenital strictures. These are usually the rarest forms of stricture. The criteria to call a stricture as congenital includes a stricture of anterior urethra found in infants before he or she starts to walk. It should not be inflammatory, should be of short length, and not associated with history or potential for urethral trauma. Moving on to the pathology or histopathology of urethral strictures. Urethral stricture is a fibrotic process with varying degrees of spongiofibrosis, which results in poorly compliant tissue and decreased urethral lumen caliber. Stricture is usually a consequence of epithelial damage and spongiofibrosis. Most of the dramatic changes that happen in urethral strictures usually occur in connective tissues. When a trauma happens, the epithelium becomes ulcerated and covered with stratified columnar cells, with increase in number of myofibroblasts and multinucleate giant cells, leading to increased collagen production and fibrosis. There is a change in subtype of distribution of collagen from type 1 to type 3, resulting in decreased elasticity and compliance. There is complete loss of orientation between smooth muscles, extracellular matrix, and periluminal sinusoids, and there is a decrease in vascular density and elastic fibers. These fibrotic changes with decreased vascular density are usually the greatest when the etiology of the underlying stricture is trauma. Hence, the traumatic urethral scar is dense, hypovascular, and has decreased elastic fibers. Signs and symptoms of urethral stricture disease. Patients usually present with obstructive voidic symptoms with an insidious pattern. Typical symptoms include a weak urinary stream, straining to void, hesitancy, incomplete emptying, urinary retention, post-void dribbling, and recurrent UTIs. Some subset of patients should undergo an evaluation for urethral stricture. These include a young patient with episodes of recurrent epididymitis, patients with signs and symptoms of recurrent prostatitis, patients of Fournier gangrene, and patients with infertility and obstructed ejaculation. When taking a past medical history, we should always inquire about history of stricture and subsequent management, history of any prior urological surgeries such as hypospadias repairs or prostatectomies, history of difficult urethral catheterization, or any history of tuberculosis, schistosomiasis, BPH, or diabetes mellitus. While doing a general physical examination, an ill-looking and febrile patient in the case of urethral stricture usually signifies infection. We should always examine the oral mucosa for suitability for harvest of buccal or lingual mucosal graft. When examining the abdomen, the lower abdomen, there may be the presence of lower abdomen pain in case of urinary tract infection or retention. Bladder may also be palpable in a patient with urinary retention. All the hernial orifices should be carefully examined. Digital rectal examination should always be done when a patient is more than 40 years of age and patients with pelvic fracture urethral injuries. While examining the genital and perineum, palpation of the penis, scrotum, perineum, and urethra should be done for thickening or indurations. Urethral meatus should be assessed for stenosis or bleeding. One should examine for any hematomas in the scrotum, penis, or perineum. You should look for presence or absence of any fistula or presence of any cordy, hypospadias, or whether the patient has been previously circumcised. Making a diagnosis and evaluation of urethral stricture. While making any appropriate treatment plan, certain characteristics of a stricture should be carefully determined, which include location of the stricture, length of the stricture, depth of the stricture, and density, which means spongiofibrosis. Diagnostic investigations include imaging studies such as retrograde urethrophy, voiding cystourethrophy, urethrosonography, MRI, CT scan, or a urethrocystoscopy. Moving on to retrograde urethrophy, it is the oldest standard currently for diagnosis and staging for urethral strictures since 1910. It is most useful for evaluation of anterior urethra from external meatus to proximal bulbar urethra. It tells us about the number, location, and severity of strictures. It should be done by ideally it should be done by the treating urologist, or at least under the supervision of the treating urologist. Patient should be taken in a lateral oblique position at an angle of 45 degrees, and a gentle traction should be given on the penis. A scout film should always be taken before the contrast is injected. This is a normal retrograde urethrogram showing the pendulous urethra, the bulbar urethra, penoscrotal junction, and the membranous urethra. Stricture characteristics and extent seen on RGU include strictures which are caused by idly instrumentation, idly happen at the penoscrotal junction, as this area is fixed by suspensory ligament of penis, and membranous urethra, which is narrow in diameter. These are usually short strictures and smooth in contour. Traumatic strictures are usually short, focal, and smooth in contour and happen at the bulbar urethra. Infectious strictures are usually irregular, have an irregular contour, are long, multifocal, and happen in anterior urethra. Limitations of retrograde urethrophy include it is difficult to assess the total distal urethral strictures which happen in urethral meatus or the fossa navicularis. The proximal part of urethra is difficult to access, such as the bladder neck. Contrast injection may be very uncomfortable to the patient and may predispose the patient to UTIs, or there may be a reaction to contrast agent. Voiding cystourethrophy, it is especially useful in assessing posterior urethra. The bladder neck opens and there is distension of posterior urethra in VCUG. Occasionally, normal anatomic structures may be opacified during RUG or RUCUG, which should not be confused with areas of extravasation. Examples of such structures include glands of litter, prostate gland, and the Cowper's gland and ducts. Opacification of glands of litter may happen with urethral inflammation or urethral stricture disease. The musculus compressor nuda muscle may also be apparent and should not be confused with the stricture. Ureterosonography, it tells us about the location, length, and stricture caliber of the stricture. A 7.5 megahertz linear transducer is used. It is best used for determining length of the bulbar urethral stricture. It is limited by stricture location and is very operator dependent. A newer extended field of view ultrasonography produces better images which can help to better access stricture length and location. As the images taken by this ureterosonography look exactly like a ureterogram. Ureterocystoscopy, it is the gold standard for determining the presence or absence of stricture. It helps us to take a biopsy from the suspicious lesions. It permits the visual inspection of bladder. Scope can be passed totally up to the stricture, but it is important to remember that it is not necessary to pass the scope beyond the stricture. Pediatric endoscopic equipment are very helpful in case of a narrow caliber urethra. It is very important during surgery to evaluate the urethra completely, both proximally and distal to stricture, with endoscopy and buginage, so that all the involved urethra is included in reconstruction. MRI, it is the best ancillary imaging modality for assessing post-traumatic pelvic anatomy, configuration of pelvic fractures, and periurethral soft tissues. In cases which it is also very helpful in cases with urethral tumors. Axial and coronal images delineate the posterior urethra, whereas the sagittal images delineate the anterior urethra. Its disadvantages being it is very expensive, not widely available, and technically difficult. Moving on to voiding CT urethrography, it has a very rapid screen time. It has the ability to perform multi-planar reformatting to lengthen the urethra and determine the stricture length and location accurately. It is a fairly expensive investigation, has a limited evaluation of anterior urethra and risks IV contrast and radiation exposure. Supportive investigations include an ultrasound can be done to determine the post-void residual urine and upper tract assessment. Urophometry shows a plateau curve profile and a PFR less than 15 ml per second. An AUS score or IPSS score can be done to quantify the severity of the subjective voiding symptoms. A urine analysis and RFTs can also be done. To make a final diagnosis of urethral strictures, we should confirm whether a stricture is present or not and confirm its characteristics as to cause of the stricture, exact site of the stricture, length of the stricture, and whether it's a complete or incomplete stricture, and assess the density and depth of spongiofibrosis. Also assess the complication of the stricture, any complications such as bladder calculi, renal failure resulting from stricture, any associated urological pathology that might affect lower urinary tract symptoms. If a stricture is left untreated, it may result in acute or chronic urinary retention, infections such as cystitis, prostatitis, epididymitis, and pyelonephritis, urethrochtonis fistula in the scrotum or the perineal region, bladder stones, renal failures. Chronic infection can also be associated with squamous cell carcinoma, especially seen in patients with long-standing recurrent strictures in the elderly and strictures in the bulb of urethra. With this, I conclude my presentation. Thank you for a patient hearing.
Thank you. Yes, Manoj.
Yes, sir.
Yeah, go ahead. And if any of the faculty or the residents have any query or comment, please go ahead. Anyway, till any of the residents or our faculty members have their comment made, I would compliment Dr. Sanyam for having made a very good presentation, and Dr. Manoj to have moderated the session well. Secondly, the few points that I want to make is, number one, it is very important that the stricture disease should be dealt in a very properly evaluated and treated, because stricture disease, once it happens, it's a lifelong disease, and never get normal urethra with, which was present before the stricture, even after what our management that you do. Secondly, second comment is about the two different kinds of disease that we get with urethral stricture. One is clear-cut urethral rupture injury, which happens in perineal trauma or fracture pelvis rupture urethra, which is pelvic floor urethral injury, which is a complete transection of the urethra followed by a retention of urine and then the management. So that is a totally different class of urethral injury, PUI. And the second class is actually a urethral stricture disease. It's not an actual, you would say, it's more of disease process rather than a post-traumatic uh, result, right? So this disease could be due to a lot of factors. It could is maybe idiopathic. It may be following minor trauma. Uh, it may be following instrumentation. It may be following catheterization, and all these things can result in fracture. But the most important part is the all individuals will fare differently with all these kind of precipitating factors. We know many of these patients, when instrumentation done or catheterization done, not all will develop stricture. Can you reduce the disturbance, please? Um, can you, are you able to see? Right.
Yes, sir.
Okay.
Yes.
Okay. So, that's a very important. So urethral stricture disease, I think, needs to be the research area now. So why some of these patients will develop stricture and some patients do not develop stricture? So that is a very important part. So, and a lot of studies are being done in the collagen metabolism. Why some people will develop fibrous stricture, some will develop a very soft stricture, some may not develop at all. So, so people are trying to prevent these strictures by various methods. We all know by when you do stricturotomy or erythrotomy, you put injectable agents like steroids, mitomycin, and then interferons, and so many work has been done to reduce this formation of stricture. I think that's the area where we need to work a lot to prevent and to reduce the stricture formation. I think that is again very important. And the one more comment on the evaluation and investigations in stricture disease. Um, in ultrasonography, we have another modality which is called elastosonography. We had studies on elastosonography from our department only, and it was published also in the journals. So elastosonography will tell you exactly the type of fibrosis developing. If it is a dense fibrosis, it is a soft stricture, or it is. So elastosonography, which probably Dr. Sanyam missed, could be one of the important upcoming investigation to know the stricture disease process. And then MR urography is also again coming up very fast, And maybe in the future, we have MR urography will tell you not only the luminal narrowing, but also the actual fibrosis of the stricture. So I think these two investigations can help us to actually know the severity of the stricture. Any comment from anybody? Or Dr. Sanyam, would you like to say anything?
So I would like to ask that when a urethral stricture disease is present, is there any French as to like under this French the symptoms of urethral stricture present? Like some books say 16 French, some books say 11 French, some say 12 French. Like what is the exact caliber as to under which the symptoms of a urethral stricture disease usually present?
No, most of the I think literature would say it is 12 French, right? So this will be so don't it would be something around 12 French. If it goes below that, usually the symptoms would appear. Above that, probably the symptoms are compensated. So that's why the symptoms do not appear till the stricture is less than 12 French.
Thank you, sir.
Yeah. Anybody has any other query? Sanyam, so you missed probably the elastosonography, right?
Yes, sir.
So,
Yes, sir.
yeah. So we, if you just go see our articles which we have published from the department, we have I think 1 or 2 articles on elasto urethral Yeah.
Yes, sir. Yes, I go through them, sir.
Yeah. And we have we are doing elastography in our hospital. We can have some kind of studies again on urethral stricture.
Yes, sir.
Anybody has any other comment to make? Any resident, any faculty? I think Nachiket had joined probably, and is Dr. Nachiket there? If Dr. Nachiket is not there and nobody has any other comment to make, I would request Dr. Manoj to give his last comments and then give vote of thanks and wrap up the session, please.
Thank you, sir. Good presentation by the same. Sir, also, sir, true that elastography is missed. And thank you, sir.
Okay.
Nice.
Thank you. Thank you very much, Dr. Manoj, and thanks all the faculty and the residents and all those who might have joined us today. Thank you very much. And have a good day.
Thank you and have a good day, sir.
Good day. Thank you. Thank you, the whole team from Malcolm for helping us. Thank you.